Good afternoon, everyone, for the afternoon session. This is going to be the spinal deformity session lectures, 3 lectures, and then we follow with the free paper. So I'm the moderator of this session, also the first speaker to here, and please welcome Professor Chiu from Nanjing. He's going to speak, follow me. So I'm going to talk about the basic updated management of the adult scoliosis, what's in and out. I'm not sure that I can answer this or not, but maybe ask Professor Q is better. This is my disclosure and my acknowledgement. Some slides I got from my colleagues. This is the outline. So if we talk about the adult scoliosis, I think we talk about the idiopathic scoliosis and the degenerative scoliosis. So I'm trying to cover both of them. This is a picture. So you can see the adult idiopathic scoliosis is the onset is started when the patient's in the teenager, and then it's progressed until the adulthood. So you're going to see the S curve like you see in the children. But for the degenerative scoliosis, it's going to be, most of the time, it's going to be at the lumbar. And you have all kind of the degenerative stuff like spondylolisthesis, lateral listhesis, spinal stenosis, stuff like that. This is one of the tables that can compare. So I talked it already. So you can see it's many papers write about this. So very rare symptoms about neurogenic claudication for the idiopathic scoliosis. So I think it's different, very different for both kinds of them. This is the classification that talk about the causes of scoliosis, which is going to be the same. The primary degenerative is a degenerative, and the progressive adult idiopathic scoliosis is from the childhood, and the secondary like tumor or something. I'm going to start with the adult idiopathic scoliosis. We begin with the King classification, that 5 types, and we know about the term something that like many years ago, like stable vertebra, the center sacral vertical line, the structural versus the compensatory curve. So I think everyone familiar with this kind of terms, and that's the foundation of our knowledge for the deformity correction and the next time. So, like the principle, I'm going to talk about principle because I think up to date, I think for the adult idiopathic scoliosis, the way of the treatment, I mean the surgical treatment don't change a lot, but it's a principle that have evolution from the past until the present. So, like in type 1 of the King, so it's an S curve with true double major, so big thoracic and big lumbar. So the principle is you should fuse both of thoracic and lumbar spine. But the type 2 is something that the people talk a lot. It's a false double major, which is the lumbar very flexible, and you can do the selective fusion of the thoracic curve only. And then for the type 3, they talk about the lower, the LIV instrumented vertebra is the first vertebra that is most closely bisected by the CSVL, like in the picture. And then for type 4, it's a C curve, like this. The LIV is the first vertebra that is bisected by the CSVL, which is a stable vertebra from the definition from the King classification in that time. And then type 5 is a double thoracic curve, so you should fuse both of them. But then there's still limitation of the King classification, such as fair to poor intra-observer reliability, like type 1 and type 2. Sometimes we miss it. Like coronal plane only assessment without sagittal plane correction, which is, we talk a lot about the sagittal profile in this era. Tough distinction between type 2 and type 3 curves. Exclusion of triple major curves. It's not include everything, every curve types. And classification based on the Harrington instrument, which I think outdated now. We use only the pedicle screw, the hooks, and nobody uses the Harrington rods anymore. So the next classification, the next evolution is going to be from Lenke in 2001. Lenke Classification used divide into like many categories, and you can see in this. I think a lot of people have seen this before. So they have type 1, 2, 3, 4, 5, and 6, which is 5 and 6 is a lumbar major, but 1 to 4 is a thoracic major. You have the main thoracic, upper thoracic, and thoracolumbar, lumbar curve. So you can, and then they use the sagittal profile to include in the classification, and also the lumbar modifier, how far the apex of the lumbar go far from the center sacral vertical line. So the principle of the Lenke classification is all structural curve, which is the major curve or the curve that you do the side bending, and then it's still more than like 25 degrees. All structural curves should be included in the fusion. A Lenke curve type 1 and 5, which is just the main thoracic and the main lumbar, and other than that, it's a non-structural, can be either treated by anteriorly or posteriorly. Like some people do anteriorly, like in the chest they do like thoracoscope or thoracotomy, or in the lumbar they do a lateral peritoneal approach and put the instruments in. A Lenke type 2, 3, 4, and 6 should be treated completely posteriorly. That's better. And in patients with lumbar modifier A and B, a selective thoracic fusion is possible too. But still, the Lenke classification still have some limitation. Like for example, like 12 or 15 rules breaker, like sometimes you think this is structural, but you don't feel the entire curve, especially in the lumbar spine. And no selective fusion criteria included, like for sure. Poor inter-observer reliability sometimes, because it's like many categories that you have to put in. And then it's two-dimensional. It's not three-dimensional. I mean, it's like they have coronal and sagittal, but they don't have the axial rotation. No lowest or uppermost instrumented vertebra criteria included. And then this one is the LIV usually located in the middle of the curve by using the Lenke classification for 3 or 4 curve A or B lumbar modifier. So then this is, I think, maybe the most recent proposed classification from Kim. I think he works with Lenke now in New York. So they review about the principle of the treatment, and they regroup the Lenke classification for the adult or adolescent, whatever, scoliosis. So every lumbar modifier A and B is come to the Kim group 1. And the Kim group 2 and 3 is lumbar modifier C, which is the apex of the lumbar spines go far away. But then for the group 2 is the main thoracic. The lumbar is the minor curve. But the Kim group 3 is the lumbar is the major curve. So that's very simple. And there we have, I will talk about more, like this. So step 1 to draw the CSVL. If it's lumbar modifier A and B, go to group 1. If lumbar modifier C, go to group 2 or 3. And then step 2, you measure the cup angle. If it's the main thoracic, it's bigger cup angle, you go to group 2. And then they divide in each, either group 2 and 3 into 2 selective fusion or non-selective fusion. This is a summary table. I break it out. Like group 1, all lumbar A and B modifier. So UIV selection criteria. You choose T2 or UEV plus 2 of thoracic major as UIV if left shoulder high. But if neutral, if even, the level shoulder, you use T3 or UEV plus 1, and then T4 for the right shoulder high. And for the LIV selection criteria, it's a new stable vertebra at the TL junction as the most proximal vertebral body around TL junction touches by CSVL, but at or below the LEV of the main thoracic curve. And then in the group 2, which is main thoracic, but the lumbar C modifier. So Number one, selective fusion subgroup is they call the group 2S, determined by the AVT is the apex apical vertebral translation. So you draw the CSVL and then you measure the distance from the CSVL. And AVR is the rotation and the cup angle. And you divide it, like thoracic divided by the lumbar ratio. If more than 1.2, they classify is in the selective fusion group. That means you can fuse only in the thoracic spine. And then UIV is about the same. T2, if left shoulder high, and T4, if right shoulder high. And LIV selection criteria is new SV around TL junction as the LIV at the TL junction as the most proximal vertebral body around TL junction touches by the CSVL, but has to be below the LEV of the main thoracic spine, a curve. This is group 2, is a non-selective fusion subgroup. So the ratio is less than 1.2. So the upper is going to be the same, but the lower you have to include the lumbar curve. So if anyone want to read it, I think I have to go. So this is group 3, is the main of the lumbar curve. So this is select fusion. You can fuse only the lumbar at 1.25, okay? And this one you have to fuse up onto the thoracic. So I think for the idiopathics, it's a change of the principle something. They have not changed the principle, but have some more details. So we go to the adult degenerative. So a lot of terms here, de novo scoliosis like that, primary. This is differences. We go. So you see the curve shape like this, idiopathic on the left side, and on the right side is the degenerative. You have the subluxation, you have stenosis, and classification as well. I will go so fast here. SRS, and then Schwab, and then the last one would be the SRS and Schwab classification. We talk about the sagittal profile, global alignment, and the pelvic parameter as well. So this could happen from the asymmetric degeneration of the distal facet joint. So that can create a curve, and usually more than 50 years old. And this is a risk of curve progression. So you can see the pictures here. I think if you talk about the update management, maybe we think about surgery, because for the non-surgery, I think it's going to be the same. Nothing so new. So the indication would be this. So fail the conservative treatment. And the goal is nerve compression. We have to do decompression, back pain, we do the fusion, and imbalance, we need correction. Okay. And sagittal imbalance affect for the quality of life more than the coronal imbalance. I think everyone knows that. Correct the sagittal imbalance more important than the correct scoliosis, and I think much more difficult. And this is the goal. Coronal plane correction in general maybe less than 30 degrees. You want a well-balanced shoulder and crest, and Caesarean plumb line is in the midline. But for the sagittal plane, maybe you don't want a positive sagittal imbalance more than 5 centimeters for the SVA, and you don't want the pelvic lateral version, so pelvic tilt should less than 20 something, and lumbar lordosis and pelvic incidence mismatch should less than 10. But it depends on the age as well. If you have younger age, maybe you tolerate less than that. You need more perfect alignment. This is a cone of economy that we try to. So the choice of surgery now is decompression alone with a limited short fusion, and the long fusion correct the entire deformity. Decompression, this is the principle, not usually recommend, but measure the nerve symptoms. Maybe you can do that, but you have to aware, because in the old days we used to do the wide open surgery, so that creates more weak to the spine more before surgery. But now we have something that better. This is a limited short fusion, so you don't want to correct all the deformity, but you just treat at the symptomatic levels. But they will have some criteria after, like this. This is the full scale surgery. It's a big surgery. lateral of the sagittal imbalance are very important, combined in the severe case. Okay. So the principle when you stop the fusion, do not stop at the apex, area of kyphosis. Severe lateral subluxation should include the spondylolisthesis and lateralisthesis inside. Upper instrumented vertebra should ideally be, I'm not sure this one, in the, like not tilt. And the iliac fixation should be strongly considered in the long fusion. You want to And this is a selection fusion levels. So L1 to TL junction, T11, T12, floating rib, maybe accept it if the UIV above the UEV, or T10. Most of the time we go to T10. And the distal level, maybe Professor Chiu will talk about the alpha S1 in the next topic. So we go from here. This is like a case deformity. This is the old-fashioned. I would say we go for, we do the conventional open T-lift and the SPO. So that can correct very well. And we use this for many, many years. But when we talk about, I go faster because the time up. Okay. Everyone talk about MIS surgery. I think if you think about the updated management of the deformities, like decompression alone, MIS T-lift, the lateral lift, or the hybrid surgery. You do the lateral lift and then plus the open surgery at the back. The MIS decompression has a role. I do it a lot because in some old patients and don't want to do the big surgery, and they have only the symptom from some part of the spine, like in one level or something. So direct surgery. Today we have the option of the endoscope to do the decompression. So this is a one-port system, but there's still some limitation investment in the equipment, something, and the small instrument. So now I perform a lot of this. Is one of alternative way to do the biportal system to do the decompression to the spine without destroying the normal structure that we don't want to destroy it. Like go inside like this. And we can do, this is like discectomy that you can perform it with use of the simple arthroscope system and then the simple instruments that you use in the spine case. This is the discectomy. So we go to the decompression. We go like this. You see the disc here, and then you take it out. Because in some deformity patients, they have just disherniation. You can do that. And this is the endoscope decompression. So you can see, I show you at the end. Use inside, and then you can go in. So it's different in the past day that you have to open it, and then you create some more instability to the segment. So this one, I think one is the option, good option for the old patients. Okay. At the end, you can see the root on the left side and on the right side, no problem from here. And then this is the MIS correction. This is a paper, I think I talked about this before. It's a talk about the ceiling of the MIS that you can use to correct the deformity or not. So use the standalone, circumferential MIS, and the hybrid. You see the red thing, the red is a hybrid that can correct more deformity in every profile. So the conclusion is, they conclude that the ceiling effect of the correction for standalone is about 23, for circumferential MIS is about 34, and for the hybrid it's about 55. That's more. And this one of the algorithm that I think is useful, that you see, if it's become the severe, you cannot do the MIS stuff. You have to do the open or the hybrid. But if it's nearly normal, like let's say there's no sagittal imbalance, you can do, it's a class 1, so you can do just the MIS decompression or just do at the segment. Like this is an example in the paper. So you see the sagittal balance is good, so they perform just a standalone L-lift, L4-5, and the patient work well. And this is, I would say, in the middle. So they perform the circumferential MIS. And then, in a severe case, SVA more than like 6 centimeter in the recommendation, so and not flexible, so they do the hybrid surgery. Okay, maybe this one do just only R4-5, like olive, and then it's just my case and my colleague's case. This is the olive plus the you can see it's correct. The coronal deformity is very good for the lateral lumbar interbody fusion. We go like that and then open. So this is considered a hybrid. If you compare pre-op and the post-op like that, so it's improved a lot. Or this case, severe scoliosis, but the sagittal profile is not so bad. So this is performed the hybrid as well. Okay, so the could correct the deformity for the MIS. It's good for coronal correction, but not too severe. The sagittal profile you can correct with the MIS. If severe sagittal imbalance, you have to do the hybrid or the open surgery. So the take home, the principle of the treatment not changed, but has more details. But the surgical techniques maybe trend to be MIS more in today. So what's in and what's out, I cannot say anything else or not, but you can choose it. Thank you.